Let's go over the warm-up review. First question, to which class of antiarrhythmics does each of the following agents belong? So we have verapamil, which is a class 4 antiarrhythmic, a calcium channel blocker. There's procainamide, which is a class 1, lidocaine, which is another class 1, and diltiazem is another calcium channel blocker, so it's also class 4. Next question, what's the clinical use for tiotropium? Tiotropium is an inhaled anticholinergic drug that's used to treat COPD. It helps to relax the airway so it opposes bronchospasm. And the last one, a patient has facial angiofibromas, ash leaf spots of depigmentation, a history of seizures, and intellectual disability. What's the most likely diagnosis? And what neoplasms is this patient at increased risk of developing? So this is a classic presentation of tuberous sclerosis. And the neoplasms these patients are at risk of include cardiac rhabdomyoma, astrocytoma, and angiomyolipoma. Now we're ready to move on to the lecture.
Whoa! Where am I?
You're dreaming.
Well, that's cool, I guess. Who are you?
I'm your subconscious.
Really? Didn't even know I had one.
Yeah, it's kind of in the name.
Ooh, can you tell the future?
What? I'm not a psychic, you moron. I'm just a part of your brain. And before you ask, no, I can't grant you 3 wishes. Hey, I can see what you're doing. It's not like you can hide from me. We are literally using the same brain.
Man, you're a real jerk.
I know you are, but what am I?
Whoa. All right, let's get on with the lecture. So let's talk about some sleep stages. Let's go through the different stages of our sleep. To this day, we actually don't know the purpose of sleep. We know what happens when we don't get enough sleep, but it's incorrect to think that sleep is a time period where the brain rests or becomes less active. The brain is doing some very complex stuff while sleeping. In fact, it goes through a very distinct stage group, and not only do we see different behaviors in each of these stages, but we see very distinct EEG patterns. So let's go through all of these. So first we have the awake stage. So your eyes are open, you're alert, there is active mental concentration going on. So this is characterized by beta waveforms on the EEG. Now remember, you need to know the EEG waveforms and how they correspond to the different stages of sleep. So remember, beta with the awake stage. Now, when you close your eyes and you're maybe meditating or just relaxing, but not sleeping yet, you go from a beta wave to alpha waves. So this is not quite stage 1 sleep yet. You're just kind of chilling out. And next we have the actual stages of sleep. So there are 2 main categories: rapid eye movement sleep, so REM sleep, or the non-REM sleep. And this is why the non-REM stages are often referred to as N1, N2, N3. That stands for the non-REM stage. So first let's talk about stage N1 sleep. So this is very light sleep. Here we see theta waves on the EEG. Now there are some books that might have stage 1 showing alpha waves. Alpha waves, remember, are seen in that kind of awake state just before sleep. You're chilling out. Make sure you know that stage N1 sleep, when you are actually asleep, shows theta waves. Now young adults will spend about 2 to 5% of their sleep time in that stage 1. Next, let's move on to stage N2 sleep. So this is a deeper sleep, and it's characterized by sleep spindles and K complexes on the EEG. Bruxism takes place in stage 2 sleep. So what is bruxism? So this is teeth grinding. Now one way to remember this is that you grind your tooth in stage 2. Now young adults will spend about 40 to 50% of sleep in this stage. So remember, sleep spindles, K complexes, and then 40 to 50% of the time young people are staying in that N2 stage. Moving on to stage N3. So this is slow wave sleep, or sometimes referred to as just deep sleep. Young adults are going to spend about 20% in stage N3. Now the waveform for stage N3 shows delta waves on the EEG. And it's actually kind of like the reverse of beta waves. Delta waves are low frequency, high amplitude waves. Stage N3 is where you have sleepwalking, night terrors, and also bedwetting. Now, what is the medical name for bedwetting? Remember, it's enuresis. Imipramine is a TCA drug. It's one medication used to treat nocturnal enuresis, and it does this by decreasing the stage 3 sleep. Now, imipramine is not first line, but it's still a treatment. Now, the time spent in stage N3 tends to decrease with age. Benzodiazepines and alcohol will also decrease stage 3 as well as REM sleep. And then we have our REM, our REM sleep here. All of the other stages are considered that non-REM sleep. Now, REM stands for rapid eye movement, and REM sleep occurs at about 90-minute intervals and makes up about 20 to 25% of the total sleep. So here we have dreaming. Patients will also lose motor tone, and males can also have erections as well. Now, sometimes this is called paradoxical sleep because the EEG shows beta waves. Where have we seen these beta waves before? Well, it was in the awake state. So the brain is using a lot of oxygen as well because this beta wave form of sleep is just like the awake state. Also in REM, we see a predominant parasympathetic state, so a vagal state. Also good to know that as well. Now, the extraocular movements during REM, that rapid eye movement, are due to the activity of the PPRF, and that is the paramedian pontine reticular formation. Pretty much anything that has rapid horizontal eye movement is going to be mediated by that PPRF. So remember, beta waves, dreaming, and loss of motor tone for REM sleep. Now, for the first half of the night, you tend to go through all of the stages in order, meaning going from wakefulness to stage N1 to N2 to N3 to REM. Now, in the second half of the night, we tend to just kind of alternate between stage 2 and REM sleep, just kind of going back and forth between those two. So now we're going to move on to changes in sleep patterns, specifically in the elderly. So as we get older, we see significant changes to our sleep patterns. Generally, older patients will have decreased slow wave sleep, that deep N3 sleep, also decreased REM sleep as well. So what are you left with? Well, you're left with just stage 1 and stage 2. Elderly patients unfortunately stay in this lighter sleep through much of the night. They also awake more frequently throughout the night as well. So they have increased REM latency, which means it takes them longer to get to that REM sleep after they first lie down and close their eyes. So definitely know those sleep patterns in the elderly. And then we also have some different sleep patterns in depressed patients as well. So we see that altered sleep pattern here. So in depressed patients, we have decreased slow wave sleep, just like you do in the elderly, but the REM sleep is different. Depressed patients actually have increased REM, and depressed patients have decreased REM latency, which means that they get to REM sleep quicker. They'll have repeated nighttime awakenings and early morning awakening as well. All right, so let's do a rapid Lewis Notes just to cement these in our minds. All right, everybody, welcome to another Lewis Notes, and we're talking about stages of sleep, and we're going to do a matching game here like we usually do, and we're going to put all the high-yield stuff where they need to go. So the first one we have here are the theta waves. Where do we see those theta waves? Remember, theta waves were in that light sleep, that's that stage N1. Bruxism, when people are really grinding those teeth, where do we put that? Remember, that's going to be in stage N2. Delta waves are super slow wave stuff. That's going to mean your deep, deep sleep in stage 3. Beta waves, where did we see the beta waves? Well, we saw them in two places, but one place that we saw them was in REM sleep, but we also saw them in the awake stage as well. What if you're just chilling out, relaxing? Where are you going to be? You're going to be in alpha wave territory. Sleepwalking, what are you going to do with your sleepwalking? Remember, sleepwalking, you're going to see that over here in stage N3, your deep sleep. You don't remember waking up and walking around. What about your sleep spindles and K complexes? That's going to be over here in our stage 2 again. Bedwetting, where are you going to see all your bedwetting? Again, that's going to be over here in stage 3. Losing all of your muscle tone. Remember, that's going to be in your REM sleep, especially if you remember people with narcolepsy, when they just fall down without any muscle tone, because they're going straight into that REM sleep. And then where are we going to find our lovely dreams? We're going to find our lovely dreams over here in REM sleep again as well. All right, guys, so that's going to be it for our Lewis Notes. So now let's move on to some common sleep disorders. So insomnia is our first one here. Very, very common. Some resources say somewhere between 30–40% of the U.S. population. This could be even low. It might be even closer to 50 or even more will have problems with insomnia. And now we're going to go over most of the medications that are associated in the treatment for insomnia. So which one of these are we going to use? What makes them unique? So the first one here is going to be melatonin. So melatonin, a nice non-addictive med. It's over-the-counter, pretty good safety profile. It's hard to hurt yourself with melatonin, but there is questionable efficacy. We're not really sure if it really works. Antihistamines, diphenhydramine, very commonly used. It's over-the-counter. It's in a lot of the over-the-counter sleep aids. You probably do want to avoid this in the elderly. That can lead to a delusional behavior. You can also get a lot of next-day fatigue if you're using those drugs as well. Antidepressants, amitriptyline, trazodone, doxepin, these work through anticholinergic effects. Unfortunately, that might give you more side effects. Think of dry mouth, constipation, that type of stuff. Benzodiazepines, triazolam, timazepam, lorazepam, diazepam, there's a lot more of those. Those are going to increase GABA activity. Unfortunately, they're very addictive. You should really only use these for short term. Zolpidem, Zaloplam. These also act at the benzoreceptor a little differently than our benzodiazepines. You're supposed to use these only for short term, but they are used pretty long term for a lot of patients. You can also get rebound insomnia when discontinued, but they're not very addictive. Izopiclone is actually very similar to Zolpidem and Zaloplam. This one does have a longer half-life, good for sleep maintenance. It could be used a little bit longer term as well. Ramelteon, non-addictive because it works at melatonin receptors instead of our GABA benzoreceptors that we've been talking about previously. You want to avoid these if there's hepatic insufficiency. Long-term studies are lacking though. Now, one extra bit of info on Ramelteon is that it can be used safely in geriatric patients. Some of the other meds can lead to altered mental status in the elderly, but Ramelteon is relatively safe. Another group, orexin receptor antagonists. So suvorexant is the example there. So orexin A and B are neuropeptides that promote wakefulness. So these drugs are not promoting sedation like all these other drugs. They're actually just blocking wakefulness. So they can be kind of a different way of treating this. So now let's move on to restless leg syndrome. So this is where you have the sensation of kind of unpleasant sensations that compels the patient to kind of want to move their legs, kind of the creepy crawlies. So this occurs during times of inactivity, and the movement temporarily relieves those symptoms. Now usually this is a primary idiopathic disorder. We don't know why it happens, but there can be some secondary RLS, things that can result from iron deficiency, end-stage renal disease, diabetic neuropathy, Parkinson's disease, pregnancy, rheumatic diseases like RA, varicose veins as well. Also just things simple like caffeine intake. Treatment, first always check iron stores, replace iron if needed since that's pretty common. Next you can use some medication, pramipexole or ropinirole. You can give those at night. If patients have comorbid pain, then you might want to consider things like gabapentin or pregabalin. Moving on to night terrors. So these are periods of terror with screaming in the middle of the night. This is more common in children, and they occur during non-REM slow wave sleep, so that's stage in 3. So remember that regular dreaming occurs during REM sleep. So these are not just bad dreams. There is no memory of waking up in these patients. It's actually very difficult to wake them up from a night terror because they are actually in a slow wave sleep. Patients won't remember walking around or speaking or doing anything weird. Benzodiazepines can be used to decrease stage 3 sleep and thus potentially decrease night terrors overall. Next, we have obstructive sleep apnea. So sleep apnea is where you have collapse of the airway during sleep, which obstructs the airway so that patient can't breathe. Now, this may be REM related, where you get that muscle atonium that impairs airway patency. There's also an anatomy component because we see this in obese patients, especially those with very short, thick necks. The primary treatment for obstructive sleep apnea is going to be CPAP. We also encourage weight loss as well. Moving on to narcolepsy. So patients have excessive daytime sleepiness. These patients, when initiating sleep, and this is important, will go straight to REM sleep without going through any of the non-REM stages. And it can result in hallucinations and cataplexy, so sudden loss of muscle tone. And it actually makes a lot of sense because we just learned that REM sleep is where you dream a lot and where you lose all your muscle tone. So you go from being awake to, boom, dreaming without any muscles. All right, so let's talk a little bit more about the treatment for narcolepsy in the study guide here. So avoidance of drugs that cause sleepiness is definitely important. Scheduled naps can help narcoleptic patients as well. Stimulants like modafinil are first line. They are a form of amphetamine, but they are a bit less addictive. You can still try some of the other stimulants like methylphenidate if modafinil is ineffective. Another strategy to prevent cataplexy is to use medications that suppress REM sleep. So these include venlafaxine, fluoxetine, and atomoxetine. Sodium oxybate may also be used if there's a lot of cataplexy involved. Next, we have nocturnal enuresis. So this is bedwetting. So first, at what age should nocturnal enuresis be treated, and then what are the treatment options? So enuresis cannot be diagnosed until 5 years of age, but both chronological and developmental age. Treatment is usually delayed until a patient is at least 7 years of age. Behavioral interventions can be attempted, like decreasing fluid intake, positive reinforcement. None of those have been shown to work very well. Enuresis alarms have the best success rate, so a horrible alarm goes off every time they pee, and it kind of wakes them up and kind of conditions them to not want to pee. There are some pharmacologic interventions. The problem with these is that there's a high likelihood of recurrence upon discontinuation. So you stop the med, they start peeing again. Desmopressin, also referred to as DDAVP. This is given orally. So what is this? Well, this is just anti-diuretic hormone. So what does that do? Well, it causes antidiuresis, so it decreases the need to urinate. And this is usually used first line, but again, as soon as you stop the med, the enuresis generally returns. Imipramine is a TCA that decreases the time spent in stage N3, where bedwetting generally occurs. It can only be used for short term, maybe up to 6 weeks. Indomethacin is another option. What does that do? Well, it decreases renal blood flow. So by decreasing renal blood flow, you're going to decrease your glomerular filtration rate. You're not going to make as much urine, and that's going to decrease urine output so you don't pee on yourself. All right, guys, that brings us to the end of our lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what EEG waveforms correspond to the different stages of sleep? So good to remember this one. So stage 1 has the theta waves. Stage 2 is your deeper sleep. That's where you see the sleep spindles and K complexes. Stage 3 is your deepest sleep with low frequency, high amplitude delta waves. And then the REM sleep shows those beta waves, just like the awake state. Next, what drugs are used to shorten stage 3 sleep? So you can use imipramine. You can also use benzodiazepines. So these can be given for enuresis and for night terrors and sleepwalking, all of which take place during stage 3 of sleep. Next, what is the sleep pattern in a patient with narcolepsy? So remember that patients will rapidly transition from the awake state to the REM sleep, which can result in that cataplexy and even hallucinations. Next, during which stage of sleep do night terrors occur? Mostly in stage N3. Remember, this is not REM sleep, therefore they are not just typical nightmares. All right, guys, that brings us to the end of our lecture here. Well, subconscious, how did we do?
I have no idea. I was busy repressing the memory of the time that you had that wardrobe malfunction at the prom.
Dude, ixnay on the empre. All right, now, time for my wishes.
Idiot.